Good evening, everyone, and thank you for joining today's webinar. My name is Janet Griffin, and I am the Director of Alumni Relations at NYU Roy Myers College of Nursing. On behalf of the NYU Myers Alumni Association, I want to thank you for joining us tonight for another faculty lecture that showcases research that's taking place at the college. So tonight we are joined by Dr. Maya Clark-Cutaia, who is an Assistant Professor of Nursing at NYU Roy Myers College of Nursing. Her scholarship focuses on the increased risk, morbidity, and mortality that results from ESRD and hemodialysis renal replacement therapy. The patient population is more likely to suffer from sudden cardiac events, and they are 2 to 3 times more likely to be rehospitalized than the general population, and they spend a disproportionately high percentage of Medicare funds. Patients with these underlying medical conditions, in particular those with multiple chronic conditions, are at increased risk of a COVID-19 diagnosis and a COVID-related mortality. Dr. Clark-Cutaia will describe how her patient population has been affected by the pandemic and how it will impact their care moving forward. She will also introduce the vulnerability of the nurses providing care to these patients in the height of the pandemic. If you have questions during the session, please enter them into the Q&A box on your screen, and we will get to as many questions as we can at the conclusion of the program. I'm going to turn it over to Dr. Clark-Cutaia, and we are so excited to have you here. Go ahead and turn on your screen.
Can you see me and hear me okay? Perfect. All right, good evening, everyone. Thank you for the opportunity to speak with you this evening. Again, my name is Maya Clark-Cutaia, and I'm going to be talking to you about patient vulnerability in a pandemic, exploring the impact of COVID-19. So here's our roadmap for the evening. In the next 30 minutes, I'd like to talk to you and take you into the lives of the two populations and discuss the vulnerabilities each group experiences. First, I'm going to tell you a bit about my interest in acute and chronic illness. And then we will have a brief overview of chronic kidney disease, largely focusing on end-stage renal disease patient population that I typically work with. And we'll do a cursory review of COVID-19, spending some time on transmission and infection. We will then conclude with how this novel disease process is impacting the communities I live in every day. I like to start by telling you a little bit about myself and some of my experiences with vulnerability that led to my research and clinical interests. I do not have a reference of Where's Waldo because my experience has been that I always blended in. In fact, it has been the complete opposite. In the military, there's an acronym, OPSEC. It's short for Operational Security. And I remember seeing these commercials on our one television channel almost on loop. They all talked about blending in with your surroundings, so you never let anyone know what we were doing as a military strategically. So let me spell that out for you. Me, on the German economy, equals not blending in. In fact, I was a celebrity. Black Americans meant hip hop legend to every German kid I have ever met. It was awesome. My parents are from what they would call a dirt road town in Georgia, whose only claim to fame is that it is the watermelon capital of the world. The only way out typically was to join the military. Literally 75% of my family has, including myself. Luckily, my dad ended up with a job that landed us in Germany my entire childhood, from the age of 4 until I graduated high school. There were some downsides to growing up overseas, though. My family rarely made it back to the US, and we often watched from afar as family members fell ill or passed away. Again, I had been in Germany since I was 4, so I didn't really understand much as this life unfolded. But because of their sacrifice, I'm a PhD prepared nurse practitioner and an Air Force veteran. Janet, you can put the next slide. Okay. So fast forward to my acceptance to nursing school. You see all these references to tokenism? That is really how I felt. I was the lone Black student in a sea of white students. We would have conversations about cultural competence and Tuskegee, and the entire room would turn around for guidance and for me to speak on behalf of all African Americans. This, of course, made me resentful, and I shied away from anything related to disparities until it hit home. My father passed away about 5 years ago from colon cancer. But before that, he was diagnosed with diabetes, hypertension, he suffered from a heart attack, was diagnosed with prostate cancer, and had a bypass. He passed away at the age of 63. And while taking care of him through all of this, I learned that his brothers, all 5 of them, had suffered a heart attack before the age of 45, and 2 of them had passed away from these heart attacks. 2 of the surviving brothers also had diabetes, and then my older sister was diagnosed with diabetes. That was just my father's side of the family. There's more chronic illness on my mother's side. So while I hated being singled out to speak on behalf of the entire population, my family medical history was forcing me to understand what was going on with my community. So who are the patients I work with? I use this picture in a lot of presentations because these 2 gentlemen embody the essence of my patient population. As you can see by the smile on our faces, the 3 of us are having a lively conversation about what I cannot really remember, but the 2 of them I will always remember. These 2 go to dialysis together every Monday, Wednesday, and Friday. They grew up together in the same neighborhood in Philadelphia. The gentleman in the black shirt works as a security guard at Temple University and has multiple comorbid conditions. The gentleman in the striped shirt is a veteran with bilateral below the knee amputations and a similar medical history. And these are the patients I have the honor of working with. So I'm going to tell you a little bit about chronic kidney disease. It's recognized as a major chronic illness, and it's growing in epidemic proportions globally. It is present in 30 million Americans. The prevalence has continued to rise annually across all stages of CKD. In 2015, it was the 12th most common cause of death, accounting for 1.1 million deaths worldwide. And it is the 9th leading cause of death in the US. Over 30 million people, or 15% of adults in the United States, are estimated to suffer from CKD, and many without even knowing they have it. The incidence is expected to increase with the rise in obesity, diabetes, and hypertension diagnoses, which are hypertension and diabetes in particular, primary etiologies of chronic kidney disease. Worldwide, there are over 2.5 million patients with end-stage kidney disease who depend on life-sustaining dialysis treatments. The incidence of end-stage kidney disease in the United States ranks among the highest in the world. At present, there are approximately 726,000 Americans on dialysis or living with a kidney transplant, 500,000 of which receive dialysis treatments, and of these, 90% receive hemodialysis 3 times a week in outpatient dialysis centers. End-stage kidney disease treatment with end-center dialysis has become more popular since 2006. In the past, patients did a lot of home dialysis and peritoneal dialysis. Those who live with end-stage kidney disease are 1% of the Medicare population, but accounts for 7% of the entire Medicare budget. So in 2019, Medicare spending for end-stage kidney disease patients totaled $35.9 billion. There are known racial and ethnic disparities throughout all chronic kidney disease stages, including and especially in end-stage kidney disease. Compared to whites, Black Americans are about 3 times more likely, and Native Americans about 1.5 times more likely to develop end-stage kidney disease. For every 3 non-Hispanics who develop end-stage kidney disease, 4 Hispanics develop end-stage kidney disease. Hispanic dialysis patients are more likely to have dialysis-related complications. Similarly, Black patients are not only more likely to have end-stage kidney disease than non-Hispanic white patients, but they are also less likely to be listed for kidney transplant. Although non-white dialysis patients have overall lower mortality rates than white patients, this may be due to the fact that white patients are usually older and have more comorbidities at the point of dialysis initiation. The data is mixed on whether more women or men are diagnosed with chronic kidney disease, as disparities vary in different databases and also across different countries. There's no clear sex-related prevalence pattern across different countries based on any metric that we know of. What we do know with more certainty is that men are more likely to progress to end-stage kidney disease and do so at a much faster rate. Just for clarity's sake, I'm speaking about sex disparities. Sex is usually assigned by healthcare professionals at birth and based on external physical anatomy. There are many individuals who fall outside that sex binary, and data is now being collected to more inclusively include gender differences. In terms of age, CKD is more common in patients 65 years and older, accounting for approximately 38% of CKD patients So we're going to switch gears and talk a little bit about COVID-19 or coronavirus. The coronavirus disease is an infectious disease caused by a newly discovered coronavirus. COVID is transmitted through droplets of blood fluid from an infected person coming into contact with a non-infected person. Individuals suffering from underlying medical conditions, in particular those with multiple chronic conditions, so like my patients that have heart disease, obesity, and kidney disease, they're at increased risk for not only COVID diagnoses, but also COVID-related mortality. There have been over 11 million cases and 246,232 deaths to date. The first patient to die from COVID in the US was an individual with end-stage kidney disease who received in-center hemodialysis therapy. So where do the vulnerabilities lie in my patient population? Individuals with end-stage kidney disease treated with in-center hemodialysis are particularly high risk for death and complications from COVID. Many of these patients have multiple comorbid conditions. They must attend in-center dialysis treatments 3 days a week, which implies the need for transportation to and from, many using public transportation. They sit in an open room for 3 to 4 hours each time to complete these sessions, and they're often immunocompromised and prone to viral infection. They have a direct line of infection risk that is accessed each time they receive dialysis that requires a great deal of care and precaution at baseline. Rates of poverty and low health literacy are high in end-stage kidney disease patients, and patients are often working in what we like to call essential jobs, requiring them to show up to work to be paid. And if they are solely on federal support, they are making decisions about their medications, transportation, meals, cost of living, and their significant others on a daily basis. The very need to stay healthy could have a negative impact on their family's survival. My patients typically live in low socioeconomic status communities with few resources, to include grocery stores. And if there are no grocery stores that are plentiful, neither are the options for healthcare, let alone COVID testing centers. There have been poor access to healthcare, and the community hospitals that exist in these neighborhoods were the hardest hit at the height of the pandemic, and will likely be again as infection rates continue to rise. As we discussed before, these patients are overrepresented. There's an overrepresentation of minorities in this population, and so there's also a concern for mistrust and stigma. Many patients do not trust healthcare providers or healthcare systems and will choose to forego care to avoid being discriminated against. Minority communities have traditionally also had stigmatizing views on infectious disease, and these go hand in hand and can negatively impact contact tracing rates, testing rates, reporting rates, and potentially even vaccination. One of the things that I'm most concerned about is that our patients often don't like to report their having been exposed for risk of, 1, being stigmatized by their family, 2, bringing others into their family members' homes to do additional testing through contact tracing. And so recently we've been really trying to stress the importance of doing all 3 of those things with our patient population. It's also well accepted that vaccination is much lower in this patient population, despite the fact that guidelines and regulations require that patients be vaccinated to be seen in dialysis facilities. What we know is that dialysis facilities that have higher rates of minorities also have lower rates of vaccination. And as the time increases, vaccination rates continue to decrease. There's also some data that suggests that patients who receive vaccinations that are currently available now, for example, flu, don't convert as well, so they require boosters. We don't really involve these patients in clinical trials for obvious reasons, but recognizing that we're now looking at vaccination and providing, hopefully soon, vaccinations for healthcare professionals, understanding how this is going to impact this patient population is paramount, but also understanding how best to protect them and get the most efficacy out of the vaccination is long overdue. Now that we've reviewed the vulnerability of these patients, there's increased risk in infection and mortality. I wanted to talk about the people who provide care to them. The data I'm going to share with you now was born from conversations with the nursing community in the height of the pandemic. While the populations are very different, their vulnerability in this pandemic are not. Many of these patients, many of these nurses were either students in the master's program with me, other nurses that I worked with doing telemedicine and seeing patients at home. There are some nurses who were doing COVID testing during the height of the pandemic. Some of them were managing patients in the ICU. The three word clouds that you see at the top are some of the things that patients talk to us about. The first is looking at concerns that really stress them. One of the things, so you see that the largest one is being in the hospital, followed by knowing what was going to come next, mask wearing. They had fears about what their days were going to be. Hours were turning into weeks, weeks were turning into days, being stressed out by not knowing what was going to come next or what the unknown was. The second cloud are things that the nurses said they used as a means of relaxation and to calm down after a busy day and to de-stress. The biggest was taking time, followed by spending time with family, yoga, being outside, taking walks, spending time with friends. But there was a lot about socialization and the need for socialization. The last is looking at, what bothers you most? What are the things that you think about the most? And most things that we heard were about the virus and taking the virus home, taking the virus to their family, being stressed out about not knowing what to do next, caring for themselves, caring for their families, and also their coworkers. So I know I'm breaking all the rules here of presentation with these large quotes, but I really felt like they needed to be seen in their entirety and I didn't want to break them up. Some of these quotes came from nurses across the country. We asked them about their feelings in terms of stress and need during the height of the pandemic. This in particular is a quote from a nurse in California. And she said that caring for my patients without adequate personal protective equipment, we learned the importance of infection control in nursing school and throughout our career, but it all flew out the window when supplies dwindled. And now we put our patients at risk for cross-contamination, cross-infection. In addition, the lack of PPE has put us healthcare workers at risk for contracting the disease, as well as our families, which is the other biggest source of stress for me. When my results came back positive, I was worried about patients, family members, or people I've come into contact with I may have infected as well. So while our healthcare force does not wear their medical history on their sleeves, they too could have multiple chronic conditions and have to consider the impact of potential exposure to their family members and colleagues. Another nurse told a story of a provider remaining in the ICU, though he was positive and symptomatic, and how it bred mistrust within the ICU community. And there was a lot of discussion about stigma for calling out or having any symptoms and discussing them, what your peers might respond or think in that regard. In the emergency department, this nurse lamented about the decisions they were making due to staffing and the allocation of resources and how it impacted everyone around them, including herself. She said, understaffing was the biggest and most dangerous issue. We were constantly understaffed, even before COVID, but as the census climbed during the pandemic peak, it became harder and harder to give safe and quality care. For example, one night I came into work and the ED census, including both COVID and non-COVID, but majority of patients had COVID symptoms, was 155. We had 15 nurses on staff to care for 155 patients, 15. To be caring for multiple intubated or unstable patients at once was dangerous. Everyone got put on a pulse ox, and you just had to try and lay eyes on everyone and hope they didn't decompensate. Then we were running out of admitted patient beds upstairs. Doctors had to resort to assigning patients who had the best chance of surviving to the ICU. One night, we were intubating a patient, and the attending turned to another attending and asked what floor they should assign the patient to. The other doctor responded, if you think they have a chance, they should go to the ICU. I won't forget the sinking feeling in my heart and stomach when I realized all my other patients were assigned to go to med-surg floors. I know my situation was probably not unique. I'm sure other nurses in New York City have their own heartbreaking accounts of COVID, but I still think about these patients to this day. We had a similar quote by a nurse in an ICU that outlined having 3 patients that all crashed at the same time and just being paralyzed by the decision of who to see first. There were conversations about the allocation of medications, taking medications from patients who they did not feel were going to make it through the night to give to patients who they thought may. They discussed changes in staffing and reallocation of staffing and having providers, in particular residents and physicians who might not have been in hospital for several years, now managing ICU patients. One nurse told me that she had a second-year urology resident running their ICU, and he just kind of gave up and had the nurses take over for him. So the nurses were telling him what to do. He was putting the orders in, but there was a lot of working together. And so there was some positive stories that came out of these decision-making processes as well. I chose this photo because of the number of nurses I had spoken to before the study embarked that talked about not wanting to be called heroes or angels anymore, because that was not how they were being treated in terms of PPE availability, other resources, and safety in the workplace. The nursing role was adapting and expanding, but they felt vulnerable and helpless. This nurse said, the stress of the unknown, not knowing if our treatment plans are helping or worsening the patient condition, the feeling of desperation and shooting in the dark as last effort to turn a patient condition around, all ending in fatality. Seeing our patients go from being alert and speaking with us to crashing and needing to be intubated within an hour, and seeing the fear in their eyes, attempting to be reassuring when I know they see the fear in my eyes too, and to see them not make it after weeks of attempt to save them. Having to FaceTime with crying family members, children, grandchildren, spouses, siblings, parents, and knowing it may be the last time they ever see their loved one. Sitting with a patient dying alone in full PPE, sobbing while holding their hand and trying to let them know they're not alone and they're loved. There were conversations like this in overwhelming abundance. Some talking about feeling alone because no other providers were going into the room. Nurses doing the majority of the work in the patient care inside the room. Physicians doing assessments from the doorways. ICU attendings and residents not managing vents because they would have to go into the room to manage the ventilators, so that the respiratory therapists were running in quickly, changing vent settings and running back out. And most of it was falling on the nurses. And again, feeling vulnerable, feeling helpless. So I say that to say that there's a lot of work to be done. As you can see, there's several areas of interest that I have. We're busy attempting to secure some funding to investigate the role of stigma, mistrust, and discrimination, and the relationship of community density to how COVID-19 resources are allocated, and whether or not, in-center hemodialysis patients will undergo testing, contact tracing, and vaccination in preparation for hopefully a vaccine to come soon. I'm also really interested in understanding sort of what the long-term effects are of the disease. Like I said, I've been spending a lot of time doing telemedicine and seeing patients from home. And a lot of the patients we've been seeing with COVID of all ages, we've really noticed that their symptoms linger. They describe a lot of fogginess and different difficulty with cognition. And so I'm hoping that we can get some funding to sort of look at what those long-term effects are in a cohort study over an extended period of time. We've also taken the COVID nurse study and translated it into Spanish so that we can use it in Spanish-speaking countries, and we should be recruiting for that soon. We have put together a report for NAM so that they can see sort of what we've been discussing and potentially how that might impact the long-term health of these nurses that are currently working in the pandemic, but also to see what that means for occupational health. Employee health in traditional sense has focused on things like injuries. We haven't really used occupational health to focus on mental health. And the question is, are Spanish-speaking countries having the same experiences that we are here in the US? And if so, how do we also, expand the data that we're collecting into something that could potentially have global effects, a global impact on nurses who are suffering likely from PTSD following this pandemic. And lastly, I am working to develop a mixed methods project to understand disparities in the delivery of care to minority patients with chronic kidney disease. I'm sure everyone is well aware of the social injustice that has been going on and discussions about what we can do. And one of the things that we're finding is that patients, dialysis patients in particular, have a conversation often about not talking about either end of life care or lung transplantation, kidney transplantation. A lot of my patients say that it was never really brought up, that it was mentioned in passing. And so I want to gain a better understanding of where these breakdowns in access to care are and what kind of causes them or facilitates them, and where we might be able to mitigate them. Is this only happening with minority patients because we assume minority patients are going to turn down the transplant anyway, so we don't bring the conversation up? Is it that we don't feel that minority patients will understand the conversation, so we don't bring it up? Or is it that we don't bring the conversation up because it's a difficult conversation and we don't enjoy being in uncomfortable spaces? So the last thing I want to talk to you about or tell you about is, having so what can we do conversation. Since the start of the pandemic and simultaneous, unrest, civil unrest, and social unrest in the country, one of the things that has really become apparent, I think, in healthcare and in nephrology in particular, is this question about what can we do? I've had literally every nephrologist and surgeon that I've ever worked with call and ask this very question: what can I do? And I think they feel that sitting in their perches, most of them have highly respectable roles that have some power. They would like to know how they can affect change in the short time that we have, wherever that may be. And so I think we've all noticed that in recent weeks, COVID infection has continued to rise, which means that my patients and these nurses are once again going to be facing their vulnerabilities, some of us as well, unfortunately. And so I want to challenge everyone to, one, be the change that they want to see. So encourage your friends, your families, your colleagues, even your enemies, to consider the health of their communities and to mask up. I don't say socially distant, because I think that there are ways to be socially engaged without worrying about distance, but definitely, talking to people about being physically distant and remaining vigilant about who they're with and who their families are exposed to. We should advocate for equitable access to care and resources to those who are most likely to be impacted, but also challenge the norm. As I said, what is going to be the impact of COVID on the mental health of our healthcare force? Not just the nurses, the doctors, the nursing assistants, who we haven't even looked at yet, but know they're carrying the brunt of a lot of the patient care, especially ADLs, and their families. What does it mean for occupational health and how occupational health changes in the future? What does it mean for staffing? How does staffing change in the future? How do we decide where medications and supplies are allocated in the future? Is there going to be an algorithm to determine patients who need to be taken off a ventilator based on their symptomatology? I mean, there's so many questions about how to manage these patients moving forward that I think we really have to advocate for thinking outside the box. And lastly, just being really comfortable with being uncomfortable. Some of us are going to have to fight to have a seat at the table. I don't know if you guys have seen the op-ed that came out recently calling on President-elect Biden to put a nurse at the table to talk about COVID and his COVID initiative. But those are things that we need to do as nurses, and not to be ashamed of it by any stretch of the imagination. Have difficult conversations with people once we have that seat at the table. If it's not you making the decisions, but if you are the person making decisions, start asking for help, admitting that you need it, that you don't know everything. Surround yourself with people who know more than you about these vulnerable populations in particular. And I charge all of us to face our own vulnerability as the pandemic moves forward. And with that, I will take any questions that we might have from the audience.
Thank you, Maya, so much. That was great. So much great information. I love that you shared all this research, and it's fascinating you've done it. I feel like in such a short amount of time too, considering that this pandemic is really quite young. Honestly, it's really just since the beginning of the year. Maybe it started before that, and across the
It
pond.
feels much longer.
It feels like we've been in this for a really long time, but honestly, it's
It
just
does.
been a few short months. So
It
I
has.
appreciate all your hard work, and it was great to hear all that you have pulled together on this so far. So I do have a couple of questions. So given the fact that we're probably going to go into a winter surge, you're talking a lot about nurses, like a nursing staff, like really all medical professionals, as you pointed out, like whether they're doctors, nurses, respiratory therapists, whoever, they're all going into this winter fatigued. They're already tired. So especially here in New York City and tri-state area. So what, I mean, are are nurses preparing themselves? Are there programs out there that nurses can use to prepare themselves? Are there hospitals that are, putting things in place to continue to take care of the staff so that we don't see that kind of high emotional stress that we saw back in the spring?
Yes, so I think the hospitals and health systems are definitely more aware of this risk at this point. I think they're trying to do small things to improve mental health. So having seminars and webinars and making sure that staff know and healthcare professionals know where they can go to talk to someone. They have set up hotlines so that you can call and speak to a provider or do a telemed visit relatively easily. I think that the concern is that this surge is going to be different than the previous one, and there's going to be a lack of resources this time, meaning providers felt that the last time when this happened, we had an army come out and protect us and support us. There were funds that were available. Those funds are no longer going to be available.
Mm-hmm.
The nurses who we saw, one in particular in our study who left her home, quit her job, and took a traveling position in New York City so that she could help during the height of the pandemic, said she's leaving nursing after this.
Oh.
So there is definitely some fear that the shortage that we had before is going to be much worse, that the illness, the amount of illness that we see in patients is likely going to be much worse this time, and that we're just not going to have the resources to meet it. And I also think that there's some concern from the perspective of healthcare providers that the healthcare systems aren't really supporting them well, in that the concern now is we have to make up the money that we lost. And so they're not taking appropriate precautions to ensure that their healthcare providers are healthy. It's a bit frustrating, I think.
Yeah. And just very concerning, I think, too. Just, we're all talking to nurses, and many of people that have tuned in tonight are nurses themselves working on the front lines. It's a concerning situation. So, but
it is scary.
Yeah, it's very scary, what the repercussions of this will be once it's all over. A lot of exhausted people, and hopefully won't be a lot of nurses like this one woman you talk to that is leaving the profession. So hopefully people will stay in it, and because we need nurses. So
I will say that, at least in my experience so far, those who are sort of leading the COVID programs and initiatives, they have been very supportive. So we have been getting emails nonstop that are, very inspiring and talk about like, yes, it's coming, but we all knew it was coming. This is how we're going to take care of each other, but also reminding us to take care of ourselves and to do what we can do, and to, prioritize self-care, which is something that nurses inherently don't do. We've always been caring for others. And so I think that's just been nice for people to give us permission to be human and feel whatever feels we're having at the time. So I do think that has changed a bit, which has been nice.
Yeah. Now, you did mention a few times that you had personally been doing some telehealth with your patients over the last several months, which this is a topic that's really a big one right now, because so many providers have had to switch just to keep their patients safe, or to keep themselves safe. But in really thinking about your patient population, how is there is this helpful for your entire patient population? I know you said there's a lot of socioeconomic factors, there's mistrust, there's stigma. Is that also happening within telehealth too? Are they, I know that there are some disparities that people talk about, that there's not, sometimes they just don't have technology to be able to do telehealth. But what are some of the barriers to using telehealth with your patient population?
Oh yeah, so we've had this argument since March. So initially when we started doing telehealth, there was this huge push to do all video visits, because you can bill differently for a video visit than you can bill for a telephone visit. So they kept stressing, it has to be a video visit, it has to be a video visit. Well, my patients have flip phones. I can't do a video visit on a flip phone. My patients also may not have internet. So unless they can go sit at a Starbucks, which also isn't in their community, they don't have Wi-Fi. So there was a lot, we pushed really, really hard against administration on that, and they have eased up on enforcing the video visit rule. What I have noticed is that patients of color, regardless of what they're seeing us for, have been very glad to see providers of color as well. And I think it has done something for the community that we haven't done in the past, which is sort of open and broaden the horizons of patients who never thought that they would see people looking like them caring for them. So that has been great. I think that it is also taken some of the fear of being exposed. I mean, a lot of my patients can't go to the ER. I really don't want them to go to the ER right now, because there are COVID patients sitting in the hallway, laying on stretchers in the hallway, and it's the risk of them being exposed is pretty high. So it has been nice that a lot of the things that we see patients for in telehealth, we've been able to sort of reduce their risk of going into the hospital. Those patients who end up going to the ED or urgent care truly need to be seen in an ED or urgent care. So it has been beneficial in that regard. And a lot of that stuff you can get just talking to a patient over the phone. I can tell if my patient can't breathe just by talking to them. I don't need to see them for that. So I think it's been a great service, and I'm hoping that we can figure out a way to maintain it moving forward.
Yeah, I know it's a hot topic right now for sure, but and the billing in particular is a hot topic.
Yes. So that's the other problem. Is insurance going to continue to pay for it? And how much work do we have to do to get paid? And so I think that's the other problem, but we'll see what happens as we move forward. I'm hoping that data demonstrates that patients do really well with it, and insurance companies just jump on board and treat it like any other visit.
Mm-hmm. Mm-hmm. Yeah, I feel like that's a whole other program topic that we'll have to have you back to talk about.
Yes.
It's a whole nother topic. So, but going back to that stigma and mistrust in certain populations, I'm just thinking about, just in general, how do you help them be more aware of how to take care of themselves? I mean, you mentioned like they don't want to report that they're sick of any kind of sickness, probably. They don't, whether it's COVID or anything else, and then don't want to go to the doctor, and then don't want to, they take whatever it is back home, and then there's no contact tracing because they don't want to share it. Like, how do you, is there a way that you're able to like add or make people aware of how to care for themselves during this time, or just in general, because I'm sure this happens during flu season every year?
I literally talk to them like they're my family, and explain, what the risks are to not protecting yourselves. And I try my best to explain, and hopefully lessen their fear that we're trying to do something to them, or that someone's going to show up and cause them harm. And I think, it is one patient at a time, but every time one of my patients comes back and says, that Maya that we talked to who told us to do X, Y, and Z, she was right. They did exactly what she said they were going to do. I think every time that happens, especially in the dialysis center, it breeds confidence, it breeds faith, and that allows patients to come back to us in the future. And so it has worked very well in that regard. The patient population I worry about is the undocumented immigrants. one, they can't typically set up telehealth visits. So we hardly ever see them. By the time we do see them, they're in the emergency room and they're way sicker than I would like them to be. Of course, this is not new. As a general surgery NP, I would have patients with appendicitis that had ruptured a week ago finally come to the ER for the same reason. So those concerns are still very real for us because that's a population we have a hard time reaching. And now in the pandemic, we can't go into their neighborhood or to their, to hang out and see and sort of build that rapport. But I do think just being really human and being honest and listening to what the patients have to say and then on my side, doing what I say I'm going to do has been really, really, really beneficial.
Mm-hmm. Yeah, I'm sure that's going to be a hurdle that you'll always be working to jump over, always.
Yeah, it's and I think in the current climate, I think that our immigrant population is feeling even less secure here. And so I can honestly tell you, I think I've seen one non-English speaking patient on telehealth since April 1.
Wow. That's very
it's dangerous.
Yes. Yes, because then your question is, where are they? Or
yes.
Go.
Where are they going? Are they passing away and we don't know about it?
Yeah. Yeah. It's a lot of questions with no answers, unfortunately.
Right. And we can't get to them. We're not in a place where we can do our usual, hang out at the local hospital or going to their local church or, community centers. We don't have that access right now. So we can't even go in and try to do these things we'd like to do.
Yeah. Wow. Well, that's good to hear that you do have these alternative ways of going in to the communities as well, because I'm sure that helps breed a lot more trust if you are in their church or in their community center. I'm sure that are great ways to reach your patients for sure. So,
and that's how I got to know those two gentlemen in that slide. I mean, they are hilarious. Every time I go back to the dialysis center, they want to know how my kids are. They want to know, what am I teaching my students? And it's nice to have that rapport because they really do tell each other, she's okay. When she comes in, you can talk to her, you can trust her. And it's nice that that rapport is built.
Yeah, absolutely. So, all right, let's see. Any more questions? Let's see. We'll give it let me see here. How do you think the potential COVID vaccine will change the landscape of the COVID-related research being conducted right now?
So that's going to be an interesting one. I honestly don't know what they're going to do with the available vaccinations that they have. There's not a lot of inoculations. I think they're saying that something like 25 million people will be able to be vaccinated here in the US. And I can tell you that most of the providers I know currently are afraid to be vaccinated as the guinea pigs. So I don't know. I'm really curious to see what happens with it. I'm hoping that the providers of these vaccines branch out and start looking at some of these populations at greatest risk for contracting the illness and try to focus on those populations first and encourage them to participate in some of these trials, but we have not been very successful. I mean, minority patients typically aren't interested in participating in research at baseline, and then now you add giving them something that nobody else has had before. That doesn't breed any trust or likelihood that they'll do it. And lastly, knowing that the dialysis patients in particular don't seem to convert all that well, and they never really build up the defenses the way we would like them to. I don't know. That's a good question, Laura. I don't know.
Time will tell. We're all very anxious to hear more about these vaccines, definitely. But as you said, Maya, I don't know that I want to be first in line for it.
I was just thinking today, maybe we need to, so when we did the nursing study, we just went on social media and said, hey, if you have time, fill out this survey. I feel like we should do the same thing and just ask healthcare professionals, how do you feel about the vaccination? And not only that, how do you feel about being the first people to get it? Laura agrees. I think that I mean, I can tell you in my tiny little clinic so far, only one provider has said he would do it. Everybody else is like, really? So I think, yeah, I was just thinking about that today, that maybe we just need to do the same thing and see what comes out of it, see what we get.
Yeah.
I mean, if we don't want to take it, why would a patient do it?
No.
It's a very real problem, and I don't think I really thought about it until we started talking about it this week. I mean, department chairs have been saying they wouldn't do it. It'll be interesting. I like that idea though, Laura. I did think about it today.
Well, and I think what will really breed a lot of trust in the entire population, not just your patients, is when you do see the healthcare workers lining up to take it. And I think that will really bring a lot of trust to everybody, and a lot of bring our anxiety levels down about taking this vaccine as well. So even though we all want it really bad,
I
it makes
know.
a little nervous to take it. So
No, and I mean, the concern is definitely rational. We don't even know what the long-term effects are of COVID.
right.
I mean, we were having a conversation. I started implementing a program to all the patients I talked to that get diagnosed and positive. I tell them, like, listen, you have to treat this like any other illness. You have to treat it like recovering for surgery. You need to do your deep breathing. You have to do your exercises. You have to walk around, because patients think that it's like the flu. It's not like the flu. It is laying people out for weeks. Some people have been sick for 3+ weeks.
Yeah.
And the symptoms linger, or it comes, in a cyclical pattern. And I don't know if we're looking at that. Like, is someone looking at a rehabilitation program and how best to ensure that patients get back to baseline? I don't know, but we should, recognizing that there has been this, long stretch of illness, and it's pretty debilitating. Even young, healthy people are saying they are being in bed, like they're just so fatigued, they have to lay down for days at a time.
Yeah, I think something that's so interesting that has come out of this is that everybody seems to know the word comorbidity now.
Mm-hmm.
It's just commonplace that everybody sort of knows this word, and it's not new anymore. So I'm sure now it helps people understand your work so much better than of what you're doing. And I hope that people do understand better why, when you have all these underlying illnesses, that something like COVID or even the flu, for goodness sake, would really be very detrimental to your health, if not deadly to your health.
No, I agree. And I feel like I should have been a public health nurse in like another time in my life, because I feel like this is the perfect time to do so many campaigns on just health in general, health promotion, disparities, risk reduction, all these things that we usually talk about that we seem to have lost. I think I spent the first half of April and May just telling people, just wash your hands, sneeze in your elbow, and cover your face. That's it. That's what we tell our kids to do. So just going back to the basics, spending some time in these communities that really don't have the resources to do it. I went after our local council person, was like, our neighborhood isn't getting the same resources that people across the bridge are getting. When the pandemic really hit, our grocery store, there were like hundreds of people in the grocery store at a time. Nobody was wearing masks. They weren't wiping anything down in between clients. Like, it was a total mess. And he was like, well, what do you think we should do? I was like, how much time do you have? And then he sat on the phone and we talked about it all, and they somehow managed to get it into place. And so I think that was the first time I had done anything like that, like just sought someone out and gave them a piece of my mind. I think that it really taught me how significant public health care is, and that maybe in the future I need to do a little bit more of it. But just, yeah, really understanding like what the public health piece is and how we can do campaigns in our community, especially in my dialysis community, to keep them healthy and safe.
Mm-hmm. Mm-hmm. Yep. So many, like you said, a lot of just commonplace things that aren't really I guess people they're not being taught, or they
Mhm.
just don't talk about them anymore. There's not a lot of emphasis on public health. So, but
Yeah.
you still have plenty of time. You could pivot your career, Maya, and go into public health. It's not too late.
Never too late.
When you get done with all your kidney research and all this COVID research,
Just move on to the next thing.
you just move on. That's right. That's the great thing about nursing. You just keep moving on to the next thing, and it never gets boring. So
That is
you're
true.
all set. You've got a long career.
I have been very fortunate. I think it has been a rough time for the country, but I think there will be some life lessons that we learn in terms of taking care of one another and what that means for healthcare going forward.
Yeah, definitely. Whew, I feel like we still have a lot of lessons to learn too. So unfortunately, but we'll see. Hopefully we can stay safe through the rest of this pandemic, and especially
one more bout of this. Hopefully that's it. I'm hoping that because it's going to get cold, we'll be inside. There'll be less potential for, unknown exposures. A girl can dream.
we can all dream. I hope that that's what will happen. So we hope. So, and as you said, wash your hands,
yes, wear your mask.
wear your mask. So they've been telling us that all along, and I'm sure, well, actually nurses always tell you that no matter what, even when it's not.
Yes, we're all about the hand washing.
Yes. Oh, we have another question here. Hi, Maya. Thanks for the important work you're doing and for a very informative talk. Going back to having the difficult conversation about referring dialysis patients for kidney transplant, my research has shown that nurses and doctors are unfamiliar with the allocation system and can unknowingly give incorrect information to potential transplant patients or candidates. Do you think it would be helpful to teach dialysis nurses and nursing students about the transplant process?
Oh, and that we should talk. So yes, I agree. I agree on all counts. What we're finding is that they really just don't understand. I mean, most providers have no idea about the transplant process. And it's complicated and it's long and it's arduous and patients put a lot of effort into it. But on the back end, patients really do well. And that's kind of what the ideal situation is. I'm hoping that we could do something like that. We're looking at talking to patients who have just been diagnosed with end-stage kidney disease kind of early in their diagnosis timeframe to see what those conversations look like, but also are really interested in looking at transplant patients immediately after the transplant. I'm in my mental health phase and thinking about, what happens to those patients who leave the dialysis center and had been there 3 days a week for 3 or 4 hours at a time, had such a huge support system within that dialysis center every week, and then get transplanted and no longer go. What happens to those patients as well? So we're thinking about looking at that group, the patients themselves and the providers, and trying to get a better understanding where that disconnect is. But I think you're right. We really have no idea about the transplant process. Not at all.
Well, thank you for that. That nurse in particular, I was so excited to see her popping that question up. She works in transplant and has for many, many years. So it's definitely a passion of hers. So thank you for that.
Yes, reach out to us because Dr. Squires and I were just having this conversation this week.
Yes, I can definitely put the two of you in.
Yeah, that'd be great.
With each other. So, okay. Any other questions for tonight? Any other questions? Either put it in the Q&A or the chat real quick. Oh, she just said we'd love to connect. So I will make sure that the two of you connect. I'll make an email introduction for you tomorrow.
That'd be wonderful.
Yeah, that'd be great. So, alrighty then. Well, Maya, I definitely
got one more. Did someone pop up?
Let me see. That was her saying thank you.
Oh, you're welcome. Thanks for coming.
Oh, here we go. Oh, I regret I came in late. You were doing wonderful work. I look forward to seeing the recording. I want to know what the social climate where people of color not only lack trust in the system, but they are afraid for themselves and their families just leaving the house, let alone getting tested or treatment for COVID.
Yeah, this is where we're at. We're trying to get some funding so we can look at just that, because it is troublesome. First of all, there is a long, complicated process to transport patients to and from these areas to be tested. Most testing sites aren't where they can walk down the street, go and come back. And then they've exposed themselves. They're concerned about exposing their families, and then telling anyone about it has been so far quite a concern. And so we're hoping we can get some funding so we can do a study that looks at patients in 9 different cities across the US. And as far as Washington State and California, looking at Massachusetts, Virginia, New York, Pennsylvania, and I think that's it. But trying to see if we can get a little bit of a smattering of all. There was someplace in New Mexico. We tried to do someplace in the Midwest too, just to see kind of what that social climate is like and what people are experiencing and whether they're doing it. And if they're not doing it, why not?
All right. Any other questions? We have time for probably maybe one more question if anybody wants to throw in the chat or the Q&A. All right, we will go on ahead and conclude the program again. Maya, thank you so much for being with us tonight. This was a great presentation, and I loved hearing about your research with your kidney patients as well as with the nurses. I think it's been really fascinating to hear more about that. So I wish you all the best with your research and all your future research projects, because I can definitely tell you have a lot in the hopper that you just haven't gotten to yet. So that's very exciting. But again, stay safe and healthy to you and to everyone who's joined us tonight. We really appreciate you coming, and I just stay tuned for, I'll be posting more events in the next few weeks. So we hope to see you again soon online. All right, good night, everyone.
Thank you. Have a good night. Stay safe.